just try to share whatever points he has said. The same thing I will try to share with you. So I think it's visible. So it's a reflex contraction of the vascular smooth muscle in the circulation in response to low regional partial pressure in the alveoli. It is not in the blood. Please remember that. So whenever the alveoli are not ventilated and no oxygen is coming to the alveoli, immediately the pulmonary capillaries which are perfusing the alveoli collapse or constrict. So it is an important mechanism for matching the regional perfusion and ventilation in the lung. Now, systemic circulation dilates when there is a hypoxia, whereas pulmonary circulation constricts when there is a hypoxia in the alveoli. Again and again, I am repeating that so that you can remember where exactly the hypoxia is there. So the response of pulmonary circulation is a protective physiological reflex that aims to divert blood flow away from the hypoxic areas of the lung to areas which are better ventilated and oxygenation is taking place. So the nature of pulmonary circulation is it's a low resistance, low pressure system. By causing localized high resistance to blood flow, it promotes diversion of flow to areas of lower resistance. So even a milder increase in the pressure by the constriction, it will easily divert the blood to the other areas because they are all very least resistance circulation or vessels. Now, what is the mechanism? There are two factors. One is oxygen in the alveoli is low, and also the mixed venous blood oxygen is also low. So there is a partial pressure of reduction in both the alveolar and mixed venous. And the site of action, as Mohit correctly said, is the pulmonary arterial smooth muscle cells. So it is the muscles are subserved with the smooth muscles, which can contract and relax to adjust the lumen size of these vessels. So these pulmonary arterial smooth muscles, they are made to constrict so that the vessel will collapse. And there are three components. One is biological oxygen sensing, which causes these smooth muscles to contract. Then there is a contraction which is happening. Once the oxygen level sensing is done, immediately the pulmonary arterial smooth muscle contraction happens. And the third is modulation of these responses, depending upon the next time when the alveoli gets opened out and oxygen comes into that same alveoli which was previously collapsed, automatically this constriction will relax and blood flow will start happening. That is what is called the modulation. So depending upon the alveolar oxygen tension, this modulation will happen. So the first there is a sensing mechanism, second is a contraction mechanism, third is a modulation mechanism to alter if there is a need to relax this muscle, that also should happen. It should not go in for a constant constriction. So that is the third mechanism of modulation. So different theories how this sensing occurs is done by, one is called direct modulation of potassium channels. So no fixed concept has been accepted. So there are different theories to describe how this oxygen level which are low in the alveoli is sensed by these muscles to contract. One is the direct modulation of potassium channels. So the potassium channels, when they are inactivated, there is no efflux of potassium. So it increases the intracellular negativity is reduced, so depolarization occurs. So once a depolarization occurs, calcium will be released. Calcium will cause contraction of the smooth muscle. So that is the direct modulation of potassium channel. Then changes in the cytoplasmic reduction and oxygen state. Mitochondrial reactive oxygen species production is increased, and cellular energy state, high energy compounds are released, and alteration in membrane bound protein function, activation of transcription enzymes via hypoxic inducible factor, alteration in cyclooxygenates or lipooxygenate systems which act on the the bilipid layer. So these 7 theories are there for the sensing of oxygen, which causes the reaction in the pulmonary arterial smooth muscles. So it is the susceptible to modulation, and HPV can either be inhibited or enhanced. This is the peculiarity of that. So direct modulation can occur through changes in the intracellular pH and temperature also. Whereas humoral modulation is done by angiotensin 2 in human beings. So because it is being a vascular response, it is a angiotensin 2 also is able to do that. And predominant modulation is by localized mediators produced by pulmonary endothelial cells in the presence of alveolar hypoxia. So mediators produced for pulmonary endothelial cells are nitric oxide, earlier called as endothelium released relaxing factor. So that is what is later identified nitric oxide. So it is continuously produced by the majority of the endothelial cells, more so by the pulmonary endothelial cells, and in a constant state of pulmonary dilatation by reducing the intracellular calcium, relaxing the smooth muscle. But hypoxia reduces basal nitric oxide production, and thus it causes the vascular smooth muscle constriction and reduces the blood flow. The other mediators are nitric oxide, prostacyclin, and endothelin. All the three are produced by the endothelial cells, and the clinical implications, when you give general anesthesia, it may lead to some areas of atelectasis. All of us know there is a 20 to 30% collapse, especially in the supine person under general anesthesia because of the elevation of the diaphragm. The basal portions of the lung, majority of the time, go into atelectasis. So there it has to, this hypoxic pulmonary vasoconstrictor reflex is the one which has to prevent the VQ mismatching. So using an unnecessarily high fractional inspired oxygen concentration during general anesthesia may not only contribute to the absorption atelectasis, but in ventilated areas, this will inhibit HPV, so potentially affect the VQ matching. And when you do one lung ventilation, one of the primary stimuli to research, that is how they found out there is a hypoxic pulmonary vasoconstrictor reflex, because after they started doing one lung ventilation only, they identified how in some patients it is not that hypoxemia is not that severe because their HPV is augmented or not inhibited. So an arterial oxygen saturation of 90% with a FiO2 of 1 is commonly accepted as the level at which some intervention is required. And epidural analgesia, they initially thought it could affect the HPV, but it is due to decrease in cardiac output and decrease in mixed venous oxygen saturation, which is another contributing factor for the HPV, and not direct effect on the like what is produced by the low oxygen levels. And in lung diseases, patients with severe COPD tend to have less of this reflex than normal patients, and they are more dependent on HPV to maintain an adequate VQ matching, which is ventilation perfusion matching. And patients with liver failure often have relative hypoxemia, which is called hepatopulmonary syndrome. And this is characterized by preserved pulmonary blood flow to atelectatic lung regions because HPV response is diminished in these patients. So they go in for this orthodeoxia and platypnea. All these things are because of the effect on the HPV. The exact etiology of this blunted HPV response is unclear, but seems to involve increase in pulmonary endothelial production of nitric oxide. So nitric oxide normally is reduced to cause the constriction, whereas in liver disease there is an increased production to maintain the vasodilatation or the normal caliber of the pulmonary circulation in liver patients. Carbon dioxide and pH, both respiratory and metabolic acidosis cause pulmonary vasoconstriction, and the response resulting from alteration of extracellular hydrogen ion concentration. So hypercapnia and acidosis have inconsistent effect on HPV. So when you hyperventilate or hypoventilate, there is a inconsistent effect. And what are the drugs which will affect the HVE? The drugs which can directly dilate the pulmonary vasculature, like the phosphodiesterase 5 group of inhibitor drugs, which affect on the cyclic GMP breakdown, so cause a impairing of the vasoconstriction. So they potentiate also nitric oxide, causing smooth muscle relaxation. So this is actually a drug used for treatment of primary pulmonary hypertension in patients where the pulmonary pressures are high, not due to atelectasis or not due to other diseases. There's a condition called primary pulmonary hypertension for which the treatment is this phosphodiesterase 5 group. The older drug is sildenafil, which is also given for erectile dysfunction in diabetic patients and other disease patients. But the next generation, taldenafil, and all those things have come into market now. And inhaled nitric oxide is also a potent pulmonary vasodilator, which is used especially in patients with brachioesophageal fistula or pulmonary hypoplasia in the newborn. Initial management, you can give nitric oxide to prevent the pulmonary hypertension that is happening. And it reduces the pulmonary vascular resistance and improves cardiac output in pulmonary arterial hypertension patients. And in pediatric intensive care, it's as a therapeutic option for treatment of respiratory failure with severe pulmonary hypertension in young children. And prostacyclin analogs, which are potent systemic and pulmonary vasodilators, are also antiplatelet and antiproliferative agents are also used. And pharmacological agents include ipopostanol, treponstinyl, and iloprost. All these things are prostaglandin analogs, and they can be given as IV infusion or by nebulization. Then catecholamines, epinephrine, dopamine, all of them inhibit the hypoxic pulmonary vascular response at standard doses. So they will encourage more mismatch of the VQ. So when you use that, you have to be very watchful about that. And vasopressors with predominant alpha actions, norepinephrine and phenylephrine, naturally they make a constriction of the vasculature, so they enhance the HPV. And the arginine vasopressin causes systemic vasoconstriction via vasopressin V1 receptor, and this has a pulmonary vasodilator properties at low doses. Even though it causes vasoconstriction in the systemic circulation, at low doses it has got a mild vasodilator property because it is nitric oxide dependent mechanism. Then endothelin receptor antagonists like bosantan and other drugs, which are also used for treatment of primary pulmonary hypertension, they also have the effect on inhibit the HPV. They cause pulmonary vasodilatation. Acetazolamide, which is commonly used for altitude acclimatization, mainly to prevent the high altitude cerebral edema. But this also seems to have an effect on the HPV by attenuating it at high responses. ACE inhibitors, which are given for treatment hypertension, they also reduce the HPV response. And hypoxic pulmonary vasoconstriction helps to match again regional perfusion, ventilation, lung. Physiological factors, this is a summary of what we said earlier, influenced the pH, PCO2, temperature, age, and ion status. And HPV increases pulmonary vascular resistance and pulmonary artery pressure, which can, if it is sustained and prolonged, can precipitate a right heart failure. And inhaled anesthetic agents, though they inhibit the HPV in a dose-dependent fashion, they are not clinically very relevant because the concentrations which we use for maintaining anesthesia, at that stage, they are not that much important. And managing acute severe pulmonary hypertension needs careful consideration to ventilation, fluid management, and inotropes. Of course, nitrous oxide is also supposed to interfere with this and cause attenuate, inhibit this reflex. And this picture will tell you how this is acting. See, this is the blue line is the pulmonary arterial branches. So this is the normal artery. So when the alveoli is normally ventilated with adequate oxygen in that, the caliber remains the same. The blood gets oxygenated. From blue, it becomes red and goes to the pulmonary vein to drain into the left atrium. On the contrary, the same vessel, when it is going through a hypoxic alveolus, where there is no oxygen, immediately it constricts and lesser amount of deoxygenated blood will go to the mix with the oxygenated blood. Otherwise, what will happen if this reflex is not there? The entire blood will go, more volume of deoxygenated blood will go and mix with this pulmonary arterial blood and reduce the saturation, overall saturation. So this is what is the simple picture which tells you about the whole process. Okay.